गेलं ना.
हॅलो
हॅलो
दुसरं टॅप करून बाई युट्यूब आता चालू आहे का युट्यूब दाबते वरचं युट्यूब दाब
नाही युट्यूब नाही पाहिजे
आता एक सेकंड नेट चालू होतं पाहिजे आता बॅकचा हे यार होता
Sanjay, you are seeing. No,
Sanjay, you are already seen on
Yes.
the screen.
but I cannot see you.
So video incoming video
yeah,
off channel.
yeah, yeah.
Yes. Welcome Marathi sir.
Yes, welcome. I'm extremely sorry, but there is some Wi-Fi issue because it has rained very heavily in Nagpur for last 1 hour.
Yes. Okay, we'll start then.
Yeah.
On behalf of MahaIP, I welcome respected Dr. Vijay Yavle sir, past president CIP, and all panelists, office bearers, and delegates also. This is second session of Immunization Dialogue. First session on immunization practice was a super hit and with more than 500 live members, live viewers, and till date it has seen by more than 3,000 pediatricians and pediatric residents as well. So I request all the office bearers of branches to forward these flyers and messages to medical colleges also, so that pediatric residents will get benefit of this. Then Dr. Sanjay Lalwani sir, coordinator of this Immunization Dialogue, along with Dr. Sanjay Marathe sir, Dr. Rajendra Khadke sir, and along with President RD sir, they are working very hard to get the best of best topics and guest speakers as well. So now I request Dr. Ramakant Patil sir to have words of wisdom at the start of the session, and then we'll proceed for the first topic on BCG and hepatitis B vaccine by Dr. Lalwani sir. Over to you, Ramakant Patil sir.
Thank you, Amol. And I cannot overemphasize this point that this has been a super hit success. I agree with you, Amol. That very fact that at 9:15, 9:16, it was to the capacity 94 and 100, and many are disappointed. They have to join through YouTube, and it is a grand success. We know that some states are conducting same program which we are giving immunization dialogue, but this is being taken as a teaching program, and 3,000 4,000 fees is charged for similar program of basic immunology and different vaccines and all those things. But because of this MahaIP platform, and I appreciate the participation of Dr. Rajendra Khadke, Dr. Sanjay Marathe, my friend Dr. Sanjay Lalwani, and every time we are blessed with a stalwart from this vaccinology. In first episode, Dr. Kasi sir was there. Today we have got past president of CIAP, Dr. Vijay Yavle sir is there, and we have got many new points which we are learning messages and learning points were there, and pearls of wisdom we are getting, and looking forward for all these things again. And today it is BCG and hepatitis B vaccine. There will be a lecture on that, and the lecture will be given by Dr. Sanjay Lalwani for first 20 minutes. And after that, there will be a panel discussion for 1 hour. The moderator will be Dr. Sanjay Marathe for this panel discussion. We'll have guest panelists, Dr. Vijay Yavle sir, and Dr. Rajendra Khadke and Dr. Sanjay Lalwani will be also panelists. So we have got these panelists, 3 panelists permanent, and one of them every by rotation is a moderator. So I request Dr. Sanjay Lalwani sir to continue. Before that, if anybody wants to say, or Dr. Vijay Yavle sir wants to say any few words, I request him. Otherwise, Dr. Sanjay Lalwani can start his lecture.
Lalwani sir, please proceed. Vijay Yavle sir is joining shortly.
I hope the screen is seen.
Yes sir, yes.
Yeah, so two vaccines which I'm going to cover today, I think they appear very simple vaccine, and the thought process was, why should we take BCG and hepatitis B for discussion? So I'm just going to run through a few of the slides, and I'm sure if there are any relevant questions, Sanjay would take in the panel discussion ahead. Now, hepatitis B vaccine, My objectives would be to know the vaccine schedules, the immunogenicity of the vaccine, what is the post-vaccination serologic testing, what are the guidelines, and what are the take-home messages. The vaccine schedule for this hepatitis B, it's a recombinant DNA vaccine, and the various schedules which we follow is birth 6 weeks, 14 weeks. Some of them have 6, 10, and 14. Birth weeks 6 weeks and 6 months. Birth 6, 10, and 14. And I think that's the one which usually is followed the maximum. So if you look at the anti-hepatitis B seroconversion rate after hepatitis B vaccination, if it is done at various ages, if you vaccinate with hepatitis B at neonatal stage, your seroconversion is more than 95%. And whereas you do it in the age group of 2 to 19, it's 99%. And as the age advances, your seroconversion for hepatitis B with the standard dose comes down. If somebody has got renal failure or immunosuppression, it's around 50 to 70%, and liver discharge. So if you do the vaccination at an earlier age, your seroconversion rates are the highest for the hepatitis B vaccination. Low seroconversion in elderly, immunocompromised, and those with a chronic renal failure, and 4 doses at 0, 1, 2, and 12 months of double dose may be required in these patients who are immunocompromised. Now, this is incorporated into an expanded program of immunization. Then immunogenicity of hepatitis B vaccine, if you look at a geometric mean titer in vaccinated against hepatitis B by different vaccination schedule. So if you have taken these 3-4 schedules and the study, the best geometric mean titers are, however, with the standard dose of 0, 1 month, and 6 months. So that's the best which gives seroconversion, but the antibodies are far higher than what it is required. So any of the schedules you can follow. Post-vaccination serological testing not routinely recommended following vaccination of infants, children, adolescents, or most of the adults. However, it can be recommended for patients who have lesser seroconversion rate, like those of CRF patients, those who are immunocompromised, those who are HIV positive, or those born with an infant born to an hepatitis B surface antigen positive woman, or certain healthcare professionals. Post-vaccination serological testing for anti-HBs is recommended 1 to 2 months after the last vaccine dose. Healthcare professionals at risk for occupational, percutaneous, or mucosal exposure. Healthcare professionals vaccinated usually have an antibody titer more than 10 milli-international unit per ml. So anybody who has taken the vaccine and has the antibody titer more than 10 milli-international units per ml is supposed to be hepatitis B immune. Healthcare workers vaccinated at antibody titer, if it is less than 10 milli-international unit per ml, should receive an additional dose of hepatitis B vaccine, followed by a testing for the antibody 1 to 2 months later. If the antibody titer remains less than 10, should receive additional 2 vaccine doses, so that usually 6 doses, followed by a retesting at 1 to 2 months after the last dose. Other more practical approach would be to receive 3 consecutive additional doses of hepatitis B surface antigen, usually 6 doses, to be followed by anti-HBs AG testing 1 to 2 months after the last dose. The healthcare professionals and antibody titer less than 10 milli-international per unit, persons who fail to develop a detectable antibody surface antigen after dose should be tested for HBs. If HBs AG positive, it's chronic infection. If it is HBs AG negative, non-respondable, susceptible to HBV infection, if exposed, treat with post-exposure prophylaxis. If healthcare professionals were vaccinated for hepatitis B in the past and is not tested for immunity, should we test them? Not required unless has an exposure. If exposures follow the guidelines, adequate antibodies, more than 10, no treatment. Inadequate antibodies, you can give prophylaxis with immunoglobulin and 1 booster dose. Post-vaccination testing is usually required 3 to 6 months afterwards. Testing earlier may only measure antibodies from hepatitis B immunoglobulin and not by the vaccine per se. Relatively sure of complete vaccination, but no documentation is required. If there is no documentation, 3-dose vaccination series needs to be followed. Post-vaccination testing after 1 to 2 months after 3 series, there is no harm if somebody receives an extra dose of hepatitis B. The healthcare professional who receives the hepatitis B vaccine series over 10 years ago and has a positive follow-up titer, at present my titer is negative, and somebody comes to you, what should you do now? Don't need to do anything further. That's clear. Current data shows that vaccine-induced anti-HBs level may decline over time. Immune memory, or what is called as an anamnestic antibody HBs response, remain indefinitely following immunization. Persons with declining antibody levels are still protected against clinical illnesses and chronic disease. Booster dose is not recommended nor in periodic HBs testing, which is there. Healthcare professional who is no non-responder after 1 series of hepatitis B has a percutaneous exposure. Suppose somebody is a non-responder and he gets exposed to hepatitis B surface positive blood. You give him 1 dose of immunoglobulin and initiate the revaccination. Post-vaccination testing with anti-HBs should be done 2 months after the 2nd series of dose. If the healthcare professional who is non-responder to 2 hepatitis B vaccination series, and then he has a percutaneous exposure to an hepatitis B surface positive blood, you give him the 2-dose HBIG. The first dose of HBIG in the dose of 0.06 ml should be given as soon as possible after exposure, and the second dose usually given 1 month later. Now, this is a standard start recommended post-exposure prophylaxis in the various category. The first is vaccination and the antibody response status of the person, treatment, what is there. Suppose, what if it is unvaccinated and he has an exposure to hepatitis B surface antigen, you need to give an immunoglobulin. That's what we do for a neonate born to a mother who is hepatitis B positive and initiate the hepatitis B vaccination series. If it is previously vaccinated and he's a non-responder, that means he has an antibody titer, no treatment. If he is vaccinated but he's not responded to 3 doses, you give him immunoglobulin 1 dose and initiate revaccination. If he is previously vaccinated and not responder even to given additional 3 doses, you need to give him 2 shots of hepatitis B immunoglobulin separated 1 month apart. And previously vaccinated but antibody response is not known, test the person for anti-HBs AG. If it is more than 10, no treatment. If it is less, you may give an immunoglobulin 1 dose and vaccine booster. So if somebody is HBs AG negative, then you have to initiate only hepatitis B vaccine series. So that's the most important chart, which we must remember, that if you are exposed to somebody who is hepatitis B positive, depending upon the vaccination status and antibody response, how do you really look at it? So conclusion, we need to have a documentation of vaccination. 1, serological testings, if required, usually done 2 months after the 3rd dose, and post-exposure management guidelines. Now, as far as in India is concerned, it is very, very important to give a birth dose of hepatitis B because it prevents the perinatal transmission from the mother to the neonate. Ideally, you must vaccinate within 24 hours, and maximum recommended time is to vaccinate about 7 days when it prevents the vertical transmission. The data available from the Indian scenario says that only around 45% of the birth cohort today gets a birth dose of hepatitis B. I think we as a pediatrician should emphasize that each and every neonate should be given hepatitis B vaccination at birth. And if the mother is hepatitis B positive, we need to give an immunoglobulin 0.5 ml on one of the anterolateral aspect of the thigh, and the other side, we must give hepatitis B vaccination schedule to cover it and to protect the child from a vertical transmission. The importance is if the neonate gets infected, the chance of him going into a chronic liver failure and hepatocellular carcinoma risk is much more higher if the neonates get infected, and vertical transmission is one of the main routes where the neonates can get infected. So that's my presentation on hepatitis B. I'm sure there are questions we can take. The next thing I'm going to speak on, second slide. You're seeing the slide?
No,
No, sir.
no, sir.
संजय त्याला डाउनलोड नव्हतं केलं का?
केलंय. Okay.
हा,
Yes.
Ale.
The first vaccine which we give to any newborn is a BCG vaccine. And I think I'm just going to go over fast with whatever literature is available so that we can have discussions on that. Mycobacterium tuberculosis is the causative agent for human tuberculosis. As you know, BCG or Bacillus climate guerin vaccine is one of the oldest vaccine first used in humans in 1921. BCG vaccine is derived from bovine tuberculosis strain, named after the French microbiologist Albert Calmet and veterinarian surgeon Camille Guerin, who performed 231 repeated subcultures over 13 years. The two common strains which are used for BCG are the Danish 1331 Copenhagen strain and the Pasteur, of which the Danish 1331 was produced in India at Gundi, Tamil Nadu till recently. The vaccine contains around 0.1 to 0.4 million live viable bacilli per dose. If you all know, it is available as lyophilized, freeze-dried preparation in a vacuum seal multi-dose, amber-colored ampule, or a 2 ml vial with a normal saline as a diluent. Now, the diluent which has to be used is only normal saline, light-sensitive vaccine, and it is deteriorates on exposure to ultraviolet rays, and in lyophilized form, it can be stored at 2 to 8 degrees centigrade for up to 12 months without losing its potency. And I think we have been using this vaccine right from our start of our practice. As a vaccine doesn't have any preservative inside it, bacterial contamination and consequent toxic shock syndrome may occur if it is kept long after reconstitution. So we all know that reconstituted vaccine should be stored at 2 to 8 degrees centigrade and protected from light and discarded within 4 to 6 hours after reconstitution. As we all know, the route, it is by a tuberculin syringe with a 26 number needle on the intradermal incision on the lateral aspect, conventionally on the left upper arm at the insertion of deltoid. It is confirmed by a wheel of 5 millimeters. The technique is very important. The injected site usually has no changes for several days. Subsequently, a series of changes, which is papule, which then becomes a nodule, a pustule, and it bursts open. And then by end of around 8 to 12 weeks, we get a scar formation. Maximum time required to scar formation is 3 months. If there is no take of vaccine after 3 months, we need to re-inoculate with the BCG vaccine because there may be a number of reasons for failure to uptake the vaccine. The ulceration at the vaccine site may persist for a few weeks before formation of a scar. The individual variation may take place. No treatment is required for this particular condition as it is a normal sequelae which is seen after BCG vaccination. The standard dose now is 0.1 ml, irrespective, that is what we give. BCG is not effective when used as a post-exposure prophylaxis at all. Immunogenicity, if you look at the data among those vaccinated as neonates, the protection by BCG against pulmonary tuberculosis is roughly around 59%. In studies where BCG was given in a childhood with a stringent testing, tuberculin skin testing screening, protection against pulmonary tuberculosis was roughly around 74%. The immunogenicity efficacy of the vaccine, BCG vaccine efficacy and the efficacy and effectiveness against meningeal and miliary tuberculosis is roughly around 85%. So it's mainly from the tertiary complications which is more effective. Protection was highest for those immunized during the neonatal period with 90% reduction of severe tuberculosis, and among school-age children who were TST negative with 92% reduction of severe disease. So its main role is preventing tertiary complications. Duration of protection, they say, after giving BCG is up to 15 years. Adverse events. Subdermal injections can give rise to injection site formation, severe ulceration, and suppurative lymphadenitis. So any child less than 1 year comes with a left axillary swelling, unless proved otherwise, is BCG lymphadenitis. Disseminated BCG disease that may occur between 1.56 to 4.29 cases per million doses and has a high fatality rate. BCG immune reconstitution inflammatory syndrome can associate it if the child is immunocompromised. BCG vaccine-related complication can rarely occur at distal site of inoculation in the skin, intestines, and bone marrow. Regional lymphadenitis, it's very clear. If the size of lymphadenopathy is less than 1 inch, you don't do anything. If it is more than 1 inch, you do what is called as a total enucleation of that particular BCG lymph node. Co-administration with other vaccines, it is safely administered with other vaccines. There is no evidence to suggest reduced immunogenicity and no safety concerns have been reported. WHO position paper, as far as the BCG vaccines is a strategy, universal vaccination strategy at birth in a countries or a setting with a high incidence of tuberculosis. A single dose of BCG should be given to all the healthy neonates at birth for prevention of tuberculosis and leprosy. If BCG vaccine cannot be given at birth due to any reasons, it should be given at earliest opportunity thereafter and should not be delayed in order to protect the child before the infection to the before the exposure to infection occurs. Neonates born to a parents or those close contact relatives with current or previous tuberculosis or with leprosy, neonates born in a household with contacts to countries with high incidence of tuberculosis or leprosy burden, and neonates in any other local identified risk groups with tuberculosis and leprosy. What is the policy for the preterm babies and low birth babies? Although evidence is limited, moderate to late preterm infants with gestational age more than 31 weeks and low birth babies who are healthy and clinically stable should receive BCG vaccination at birth or at the latest upon discharge from the neonatal ward into the community. Contraindication, of course, are very few. They are mainly congenital immunodeficiencies, severe immunodeficiency syndrome, patient undergoing immunosuppressive therapy, and exposed to immunosuppressive treatment in the utero. HIV infections. Now, neonates born to a mother of an unknown HIV status should be vaccinated as the benefits of BCG outweighs that the risk. Neonates of unknown HIV status born to an HIV-infected woman should be vaccinated if there are no clinical evidence suggestive of HIV infection, regardless of whether the mother is receiving ART. Although evidence is limited for neonates with HIV infection confirmed by early virological testing, BCG vaccination should be delayed until ART has been started and infant is confirmed to be immunologically stable, having a CD4 count of more than 25%. BCG in older age group. Recommendations: if the child is unvaccinated or if it's TST or interferon gamma release ACR negative, older children, adolescent and adults from setting with high incidence of tuberculosis and high leprosy can be given. Unvaccinated and those who are negative adolescent and adults moving from low to high tuberculosis incidence or leprosy burden setting can be given, and unvaccinated negative for TST or IGRA at risk of occupational exposure in a low or a high TB areas like healthcare workers, laboratory workers, medical students, prisoners, and individuals with occupational exposures. Migrants from a higher tuberculosis incidence countries who are moving to a low incidence countries, if not already vaccinated, should be tested for Mycobacterium tuberculosis. Vaccination is not required. Revaccination. Studies have shown that there is no additional benefit by repeating BCG vaccination. So a single shot is that's required. Therefore, revaccination is not recommended even if the TST or the IGRA test is negative. The absence of BCG scar after vaccination is not indicative of lack of protection, and that should be remembered. Neonates born to a mother with pulmonary tuberculosis, asymptomatic neonates born to a mother with a bacteriologically confirmed pulmonary tuberculosis should receive preventive treatment if TB disease has been excluded, and should be regularly followed to verify absence of tuberculosis. If an infant remains asymptomatic, has no immunological evidence of TB at the end of preventive treatment, and is HIV negative, BCG vaccination should be provided using a normal infant dose. So I think BCG, one of the things which have now been coming up is a recombinant BCG, which is now the new one which Indian manufacturers are looking, saying that it will be much more effective, not only for preventing against the tertiary complication, but also it will be much more protective against pulmonary tuberculosis. And I think days are not very far that we could get a recombinant BCG replacing our standard BCG, which is our day-to-day practice. Thank you.
Sir,
Thank you,
I have
Doctor.
only one question. See, the problem is basically when we talk about immunology, we talk about the short incubation period and long incubation period. Hepatitis B, hepatitis A are long incubation period illnesses. From this, where this serotiters have 10 international unit per ml has come up, I really do not get a reference, because basically if I am vaccinated and I have a record for vaccination of hepatitis B, and even if my titers are low than the 10, I am still protected because of long incubation period of hepatitis B. That is what we teach. So what is there? Is there any reference to say that basically 10 units has to be there or something like this?
Sanjay.
Dr. Khadge, what they have seen that if you have titers more than 10 milli international units, you are seroprotected. And there are studies in which they say above 10 is seroprotected. Why it is important in hepatitis B? Because it is easily preventable disease. Now you imagine, suppose you have taken 3 doses, but you are not officially seroconverted by doing a test. There is every possibility that you might not have seroconverted adequately. And now suppose you are exposed, you are likely to get hepatitis B infection, which is going to be a fatal in future also. So what they say, if you have not done seroconversion, though you have taken 3 and 95% or 96% of the patients will get seroconverted if they are immunocompetent. There is a small risk which nobody would like to take. So they say you take hepatitis B immunoglobulin, take the vaccine and ensure that you have been seroconverted subsequently. This is because of the safety procedures, because hepatitis B is not a very safe disease as compared to hepatitis A. And therefore that cutoff has come. Like for hepatitis A, now from 20 they have come down to 10 also. So there is still fluctuation for hepatitis A. But in hepatitis B, they are quite sure. There was one symposium, I think National Symposium on Hepatitis B, All India. And in that also the research paper, they said 10 milli international units is a good cutoff of seroconversion. I think that is the basis why 10 is taken in hepatitis B.
Sanjay, I think if I may intervene here,
Yeah.
What Khadke sir is asking is, how have you derived of 10? So, see, hepatitis B vaccination is one vaccine where there is a serologic correlate of protection.
Correct.
And like, you compare the efficacy and extrapolate the, compare the relative antibody titers. So 10 has been, agreed upon as a protective titer. What he's saying is, how have we arrived at that figure of 10? Why not 5? Why not so? So that is with every vaccine, you have a serologic correlate of protection. That based on the efficacy data, they have made 10 as protective titer. And now since the incubation period is very long, even if you are vaccinated, that is what Sanjay also said, that if you are vaccinated and you have documented seroconversion, and at the time of exposure, even if your titers are below 1, you are still protected because there is enough time by long incubation period for the anamnestic response to kick in and protect the individual.
Absolutely. I agree.
So how practical it is to check whether these are responders or non-responders? And if we are saying that cell-mediated immunity is going to protect you even if you have got less than 10 milli international units, so how much water does it hold to test these and label them as a non-responder and give hepatitis immunoglobulin?
No, you may be a non-responder also. No? What is the guarantee that you are a responder?
Ramakan, it is not the cell-mediated immunity. When the titers are below 10, since the incubation period is long, and by virtue of immune response, you mount a immune response quicker than the incubation period. We don't rely on cell-mediated immunity in hepatitis B.
Yeah.
It is the memory cell. It is the memory cell which is going to work.
Yeah, it is the humoral antibodies which will work, and that is what we presume. And since incubation period is long, the time taken by the immune memory to kick in the antibody above 10 is shorter than the incubation period.
Yes, sir. I think what Dr. Ramakant is asking, that I have taken 3 doses. But what is the need of doing a seroconversion and testing? And suppose I'm exposed again. No, suppose I'm exposed again. And when we know that the amnestic response is going to happen, if I'm exposed to hepatitis B, what is the need of giving hepatitis B immunoglobulin? Therefore, I say, not sure that whether you are a non-responder.
Correct.
Therefore, you must take hepatitis B immunoglobulin.
So in life, if once you have documented you have seroconverted, then
it is not required.
Absolutely. So Sanjay, you can take the panel discussion now.
We can take remaining questions afterwards. We may start with the panel discussion, and we have got this time a guest panelist who is past president of CIP, Dr. Vijay Yolesar, who is authority in infectious diseases and vaccinology. He has published many papers and contributed in many textbooks. So I request Dr. Sanjay Marathe to, as a moderator, to proceed with panel discussion along with panelists Dr. Vijay Yolesar, Dr. Rajendra Khadke, and Dr. Sanjay Lalwani. And we can take the questions of chat box afterwards also. We can note it down. Like there are few relevant and more practical questions are there on BCG and other this thing. So we can take it at the end of the panel discussion.
Thank you so much, Dr. Ramakant, Amol, Shyam, Milind, and Mukund for giving us this scientific platform. Today, we are so fortunate to have Dr. Yolesar, who is not only our teacher, but who has taught us immunology for last so many years. And we will still continue, we'll be very happy to be his students for another 20 years. Thank you, sir, for joining us.
Your modesty la salam, sir.
Very nice. Then we have Dr. Lalwani, who has already presented such an excellent 2 vaccines on 2 important vaccines, BCG and hepatitis B. And he has made the things so clear. I think there will be very few questions in our mind. And we have Dr. Rajendra, who is a ACVIP member. And always I'm always worried if he asks some questions, then there must be some Google in it. So I'm very worried about Rajendra because he's always reading something or the other and he will ask you very difficult questions. So today we'll go ahead. Because what we have decided, Sanjay has already covered BCG and hepatitis B, and I'm supposed to cover DPT containing vaccines. These 3 vaccines are very important in our national immunization program. 90-95% for that practical, but 100% of the pediatric population is going to get these vaccines. Therefore, we are giving a lot of importance. DPT has become very famous, not because it is very important, but a lot of discussion on our cellular and whole cell pertussis and this and that, and every CME or every conference, you will have at least one discussion, one CME on acellular and wholesale, which is, I think, there is no end to this discussion. Now, there are many questions in our mind also. So what I have decided, I have divided my panel into 5 groups. One is basic DPT, primary doses. Then I have taken boosters. Then I have taken boosters in adolescents. And 4th is DPT in pregnancy. I think it is all important for us. So let us start with this DPT. I will share my presentation. Yeah. Is it visible also?
Yeah,
Yes.
yeah.
So the questions are not distributed to anybody, and these are practical questions. Our aim is to give take-home messages to the audience and make our ideas very clear. They should not go with any confusion in their mind. They're basically practical questions because our CME is based on the CME for practicing pediatrician. I request all the panelists to be crisp. There are many questions in this, and try to give some take-home messages for the audience who is listening to this. As I say, vaccinology is a dynamic science. Recommendations might change with the evolving research. So don't be surprised tomorrow some different recommendation has come, like HPV from 3 doses to 2 doses to 1 dose, typhoid from 2 doses to 1 dose we have come. So it might change. That does not mean that today we are wrong, because tomorrow we are wrong, because whatever we have said today may not be true after, say, 5 years. We discuss evidence-based science only, and conflict of interest is nil. Now, before I go, because I have not taken many questions on BCG and all that, this is a simple question. I think Rajendra, sir, you can take this. 32 weeks premature, 1.7 kg, was admitted in NICU. He received antibiotics, blood and IVIG, and he was discharged after 2 weeks. That means now he is 34 weeks. When should I call him for BCG, OPV and HBV, and why?
Sir, here I want to know at what time the child was discharged. Whether the child was discharged after 30
Today.
days or whether the
I
child
have
was
said
discharged after
that
45 days.
child was discharged after 2 weeks. I have mentioned it.
Okay, okay.
So
So
now the
basically,
child is 34 weeks, and now he is day 1 of discharge.
okay. Sir, BCG and OPV and hepatitis B vaccine can be given. BCG basically works through your cell-initiated immunity. So that can be given. Oral polio vaccine is basically mucosal vaccine, though it is a live vaccine, we can give it. And hepatitis B vaccine is a killed vaccine, so we can give it.
So that means, though IVIG given to a child, that recommendation is basically for the live injectable vaccines, not for the oral. And here the BCG, the immunity is through the T cell, which will not be interfered because of the IVIG which was given. So all the 3 vaccines can be given. HBV being a kill type of vaccine, there will be no interference. So all 3 can be given without any problem. What about the DPT, HEP, PCV, Rota should be postponed because he's a premature baby?
No, it should not be postponed. It should be given a chronological age of the child. There is because DPT is also a killed vaccine. HIV is also killed vaccine.
No, because of the prematurity, I'm saying should be postponed vaccine for by 2 or 3 weeks or 4 weeks, because the child was prematurely born.
So premature baby requires more protection than the.
Absolutely, that is what is true. I
Sanjay,
think we should go.
Sanjay,
Yeah.
the one point that I would like to add here, this baby who's received hepatitis B, who's
Yeah.
preterm less than 2 kg weight, this should be taken as an, it's a must to give as early as possible, but he should receive an extra dose. Because studies have shown that
Yeah.
response to hepatitis B, when given at below 2 kg or less than 28 days of life, is suboptimal.
So now the recommendations have changed completely. The WHO has made it very simple. Irrespective of the weight, you give hepatitis B at birth, and then you give 3 more doses. which otherwise also we are giving.
3 more doses. Yeah.
So we are giving otherwise.
Otherwise also we are giving those 3 doses.
Correct.
So
Correct.
don't unnecessarily waste your time in saying whether mother is HbSSG positive or what. You give hepatitis B at birth and you forget this dose
Yeah.
and complete the schedule as we are giving 3 additional.
True.
I think the message which Sanjay needs to be given to the audience and pediatrician per se, that wherever they are attending a call, I think the coverage of hepatitis B birth dose is still a concern. And I think still a sizable number of neonates don't get the birth dose of hepatitis B. And I think that's the single most pillar on which we can prevent the vertical transmission of hepatitis B from the mother.
Sanjay, it has come in the next question.
Yeah.
So this question is for Sanjay only because he was explaining it all. Dr. XYZ gives BCG, OPV and hepatitis B vaccine to all the newborns on 1st and 15th day of each month. Is it okay? And birth dose of hepatitis B, what is its importance and when it should be given?
So I think I did mention in my presentation, the hepatitis B birth dose is mandatory. It has to be given for the best efficacy and the prevention of vertical transmission, ideally within 24 hours. If by any chance, if it's not possible, I think the maximum effect of prevention of vertical transmission is 7 days. So you should not wait for 15 days. It's a frank this thing. But both within 24 hours is the ideal. Exceptional circumstances, not maximum beyond 1 week.
If we give it within 24 hours, it is called as timely dose given of BCG. And even when it is given after 24 hours, it is called as late dose of the BCG. This hepatitis B. Sorry. So timely dose of hepatitis B and late dose of hepatitis B. So if you give timely dose, then there is almost 90% chance of prevention of vertical transmission. So I think that is the greatest advantage of giving hepatitis B at birth, preferably within 24 hours. Now the question for Yevle sir, we'll go to the primary doses. Sir, I'm quite confused about the various vaccines that contain tetanus, diphtheria and pertussis. Can you explain what kind of and these different vaccines are available?
So as the name indicates, you have 3 antigens, diphtheria, tetanus and pertussis. Now there are differences in terms of the antigenic content and the type of the antigen that is used. Tetanus toxoid is same in all the vaccines across the board, the tetanus toxoid content. Whereas when it comes to the question of pertussis, you have the age-old standard conventional wholesale pertussis vaccine where the the whole bacterium pertussis is used, inactivated. And then you have refined components. There are different components which are available, and pertussis toxin being the most important crucial component of all these different components. And based on the number of components, you have 2 component vaccine, 3 component vaccine, and a 5 component vaccine. And then the antigenic content of the pertussis, you have low dose pertussis vaccine, which is connoted by small p, where the antigenic content is 1/3 of the standard dose DPT vaccine. And then as far as diphtheria is concerned, diphtheria you require higher dose in children. As the age advances, the dose is reduced, and you have low dose in that small d. So many of us, especially those in public health setup, we use capital T small d vaccine that is used in pregnancy and in adolescents and adults in place of Tdap, which is not available. So these are basic differences. So wholesale and acellular pertussis, the type of antigen used and the quantity of antigen used.
Very clear. So friends, it's very clear. Just to avoid any confusion in subsequent discussion, I would like to make it. Capital T, small d, small p is Tdap vaccine, which is available either as Boostrix or Adacel. It's a vaccine to be used after 7 years of age. And DPT or DTAP, these are 2 vaccines of different brands are available. These are the vaccines to be used in first 7 years of age. So there will be, in the further discussion, there will be no confusion with us. Whenever I say Tdap, it is the vaccine to be used after 7 years. When I say DTAP or DTWP, this is the vaccine to be used in below 7 years of age. Now, Dr. Rajendra,
Sir,
there are a couple of questions. Let us go one by one. why do you think DPT vaccine to be given on a priority? Because even it has been included in NIP and every child gets this vaccine. So what is the importance of giving this DPT vaccine?
Sir, the DPT contains 3 antigens. So D is basically diphtheria is down, but there is something which is called as immunological shift from a childhood to the adolescent and adult. So the diphtheria is still there. Diphtheria has been down, but it is not gone. Secondly, pertussis, your natural dose of the natural infection of pertussis doesn't give you 100% protection about the pertussis. So you need to give vaccine. And tetanus you cannot eliminate because it is always there in the soil. So tetanus you cannot eliminate. So all these D, P, and T vaccine is necessary as a priority.
So we must give, because the natural infection does not give you adequate protection. And even if the natural infection or the vaccination, it is going to, the immune response is going to wane off so fast. So after say 8 to 10 years, there is no protection available. So you will have to go on giving the boosters to maintain that level. And we have seen there was an outbreak in California when inadequate vaccination was given. We have seen in our own country increasing number of diphtheria and pertussis cases in adolescents. And if our country where coverage is around 50 to 60% only, then we might get even the cases during young pediatric patients. As you were mentioning in Aurangabad, you are getting many pertussis-like infections at present.
We are seeing a lot of pertussis.
That is because of the inadequate vaccination. Now the question based on what Sanjay has already said, why do we need more doses, boosters in DPT containing, but not in the case, the question will be why you want more doses in DPT, but not like live vaccine 1 or 2 maximum doses. What is the reason?
See, the problem with DPT is the antigenic content of DPT required with a primary schedule is necessary to give some protection against DPT. So it has been, because of reactogenicity, it has been divided in a 3 doses schedule.
Okay. So we cannot give very high dose in one single shot.
That
So
is the reason why we have divided in a primary series as a 3 doses. Otherwise, the antigen content which is required to protect is all 3 in 1.
And when we give more number of doses, the immune system is repeatedly stimulated to get a better response. And still we call it as primary doses. We do not call it as boosters. Now, what is the schedule recommended by ACVIP for DPT, and why the primary schedule is different than ACIP, that is CDC guidelines in our country?
Yeah.
See, the problem is
246, we use 6, 10, 14. So what is the rationale?
It all depends upon your incidence of the diseases and the population which we are catering. So basically, if the incidence is more, we want early protection. And that's the reason why we are using it 6, 10, and 14 weeks. Otherwise, 2, 4, and 6 is an ideal schedule, but it is used in West countries because there the incidence is very less.
The disease burden is very low. So we'll always prefer to protect every child by say 14 weeks of age. And we have seen that even in first 2 months where there is no protection offered because mother has never received pertussis vaccine, then they are at a risk of developing very severe disease of pertussis and high mortality. So we would like to give as early as possible. So we have accepted this 6, 10, 14, whereas the Western world has preferred 2, 4, 6. These are the different vaccines which are available in the acellular group and the different contents. Dr. Yevlezer, now there is a lot of discussion between TH1, TH2 and TH17 in terms of pertussis vaccine. And they say if you get TH1, TH17, it has got a better immune response and better cell-mediated immune response, a longer protection. Whereas TH2 gives you little less, longer protection and immunologically slightly inferior. So what is your comment on this TH1, TH17 and TH2?
So it is seen that when you use wholesale pertussis vaccine, the immune response is skewed more towards TH1, TH17 type, which is extremely important for diseases which are transmitted mucosally. And for the mucosal, clearance of the organism, you require this Th1, Th17 type of immune response. Whereas the humoral response, typical humoral response is Th2 response, which is more antibody dependent. And that is why it is said that pertussis, which is a mucosal infection, if you use wholesale pertussis containing DPT vaccine, it is just supposed to, also halt transmission by way of this mucosal clearance because of the Th1, Th17 response, immune response.
Can we say that the Th1 and Th17 mimics the natural infection?
Well,
And therefore,
yeah, so that's the easy way of remembering. Yes, Th1, Th17 will be
so
more
that it helps in
natural
preventing the transmission through the mucosal.
Yeah.
Thank you, sir.
There is a claim in Infantry's exam.
Yeah, I did not mention because I did not want to go into the controversy. And particular vaccines we will not highlight, so that we will not discuss on that.
Okay.
Well, but now that he has raised, let us clarify to all the delegates.
Yeah.
It is claimed that the IPV containing the TAP vaccine, by virtue of the IPV present in it, it skews the immune response towards Th1, Th17 by the TLR, stimulation. However, I mean, this has been proven in animal models. We really do not know whether that can really be translated to human, better human immune response like Th1, Th17. But that is the claim that the company makes.
Company.
So as we go along, we'll discuss more about pertussis acellular wholesale.
Dr. Rajendra, I think this is a very interesting question for you. See, the concept is that if you keep any vaccine in, say, 0 degree, it is very safe. And any vaccine which is exposed to the heat is damaged immediately. And that is one of the reasons that pediatricians will try to keep everything in the freeze or a refrigerator. And to just make them very clear about this, the vaccines which are freeze sensitive and vaccines which are heat sensitive, and they are equally damaged if they are exposed to a particular temperature. My question to you, where you should store this DPT vaccine, and what are the important side effects seen with this vaccine when you give it? Then we'll go to the another last question.
So there are the vaccine. There are a few heat sensitive vaccines, and there are few cold sensitive vaccines. DPT is a cold sensitive vaccine. So if you freeze that vaccine, you will have more adverse effect with DPT.
So never ever keep it in the refrigerator.
Never ever keep
That is the take home message.
That is, and 2 to 8 degrees centigrade for all vaccines is necessary. So 2 to 8 degrees centigrade is the only temperature which we should maintain in for all vaccines, whether it is live vaccine or whether it is kill vaccine.
For a polio, there is VMM. Why there is no VMM like this for the DPT vaccine?
Because it is a cold sensitive vaccine, and the exposure, there is something which is called as shake test.
I think for the heat sensitive vaccine, there is a cumulative heat toxicity. And therefore, when the OPV is exposed repeatedly to the particular temperature, then it is damaged. Whereas in case of cold sensitive vaccines like DPT, once it is exposed to the temperature less than 2 degrees for a particular time, it has lost its potency, you have more side effects, and it is irreversible. So you cannot keep a VMM. So that is the most important thing in DPT like vaccine. Never ever should keep it in the freezer compartment. And suppose you have seen that it has been exposed to the 0 degrees, what you are mentioning is a shake test. I think those viewers who are working with PSCs and Anganwadis, they must know what is the shake test and how to demonstrate whether the vaccine which has been exposed to the particular temperature has been damaged and should not be used. For that, you have to use shake test. Those who are interested in shake test, I think they can just refer it to any manual. Very simple test you can perform, but usually it is performed in a multi-dose vial. So we may not discuss. For the single dose, you can just throw it if you feel that this is not a good vaccine.
Yes, sir.
I think the last question we have already answered.
Yes.
So friends, we'll all remember there are heat sensitive vaccines and cold sensitive vaccines. Cold sensitive vaccines are more dangerous for us because once it is exposed, it is gone. So be careful and always keep.
All vaccines which contains T are cold
Absolutely.
sensitive.
Yes. So the best temperature for all the vaccines is 2 to 8 degrees. I think this should be the take-home message for all our friends. Sanjay, it's a $1 million issue, and I think never ending also. What are wholesale and cellular pertussis vaccines? Why so much of discussion on DTWP versus DTAP? And what are the major issues, advantages and disadvantages in short?
Yeah, I think as far as the DPT's vaccine we all are using in practice, either in the government schedule or in a private schedule, we are using a combo vaccine. No one of us is using DPT, either it's Penta or the Hexa. As on today in the government schedule is Penta wholesale. In a private, either it's a cellular Hexa in any of the forms, or we have the Hexa wholesale form. As Vijay mentioned, that the difference between these two vaccines is that the serological correlates for DPT, for diphtheria and for tetanus, but pertussis, we don't have a serological correlate. That's number one. The difference between the two is that the pertussis component of this DPT, the seroconversion is the tune of 70-75%. And over the period of time, the pertussis immunity wanes. Now, it is scientifically proved that over a period of 6 to 8 or 10 years, the pertussis seroconversion drops down, and to an acellular, it drops down slightly at a more level than that of the cellular vaccine. The question is, the people say that the vaccine which is acellular has less effectivity as far as the pertussis component is concerned. There are side effects with the wholesale pertussis vaccine, which we all know, in a form of fever, in a form of convergent encephalopathy, hyporesponsive, hypotensive episodes, and of course convulsions. Now, all these side effects are because of the antigenic component of the cell wall of the pertussis. By removing this unknown antigenic component of cell wall and maintaining those antigens which are requiring to stimulate the immune system, we have this acellular pertussis vaccine. The major advantage of acellular pertussis vaccine, why it is used, is because it has less adverse effect in the tune of 80% or so, which comes down by a acellular pertussis vaccine. That's the first advantage. The second advantage is, of course, the wholesale pertussis vaccine. Immunity-wise, it's my frank opinion, it's a shade better off because you get a better response against specifically. All the controversy of DPT is against the immunity of pertussis and the side effect of pertussis. Nothing is with diphtheria, nothing is with tetanus. So wholesale pertussis vaccine gives a better immunity, which is lasts much more longer, but it has associated adverse events. The acellular pertussis gives the immunity, but which wanes over a period of time. And the biggest advantage is, of course, the number of adverse events. As far as the government schedule goes, it's going to be always wholesale pertussis vaccine because such a large birth cohort to vaccinate, and financially it is more easier to procure the wholesale pertussis vaccine and give. My personal opinion in practice is there are side effects, and I think we have seen maximum what we see is fever and the inconsolable cry which we see. Hypotensive, hyporesponsive state, convulsion and encephalopathy are that way a very rare things to happen. But if you get two of the contraindications like anaphylaxis or you get what is called as encephalopathy, then they are also contraindication to give the acellular pertussis vaccine. So you cannot give the acellular pertussis vaccine when you give the anaphylaxis and the encephalopathy. For counseling for patients, I personally think so. That is $1 million question.
Sanjay, will stop here. My question is, from your answer, it seems that you are more convinced with the acellular vaccine is better than the wholesale. But if I say in our own country, where 80% or 85% of the patients are getting wholesale pertussis, and I don't think they have come across very major side effects, neither we have seen them, that patients have been referred to private practice because of the serious complications or even many doctors are using wholesale pertussis vaccine. The side effects are, I think it's an overhyped side effects of the wholesale pertussis. That is my personal opinion, that we might get few cases of fever and all that, but can be managed very comfortably. That is one. And now my second question is to Dr. Yevle, sir. So suppose we consider the vaccine efficacy, which is immediate and long term. The wholesale pertussis vaccine helps in prevention of transmission at low cost, which is available. Definitely having little more side effects, but the cellular vaccine, which is quite costly. Don't you think that it is very painful to explain the relatives that there are two vaccines, one is painless and second is painful? And we never discuss the merits of the wholesale and acellular pertussis, because all the patients who are coming to your clinic will say, sir, wo painless wala vaccine dena. So don't you think that this is a wrong way of promoting particular vaccine as a painless and a painful vaccine? Sir, aap unmute karna. Sir, please unmute.
Okay. Can you hear me now?
Yeah.
So Sanjay, I would like to take a couple of minutes here. First of all, as Sanjay very correctly said, the confusion with pertussis component. Now, when it comes to long-lasting immunity, whether you get a natural infection or wholesale pertussis antigen as vaccine or acellular pertussis, it does not offer you lifelong protection, number one. Number two, pertussis is a very tricky disease. To have a good control and prevent outbreaks, you need a very high level of sustained coverage. And pertussis occurs in cycles, 3 to 4 years cycle. So while I'm a very strong, proponent of use of a cheap and easily affordable vaccine, which has stood the test of time, though there is no efficacy data on the wholesale pertussis containing DPT vaccine, we know for last several years the disease burden that has gone down. It is the proof of pudding that there is effectiveness data, I would say. No efficacy data, but we have effectiveness.
Real-time
effectiveness data on field. However, first and foremost, let us not call them painless or painful vaccine.
Very unfortunate.
It is unfortunate. When patients say that give me painless vaccine, I tell them that the pain is less.
Correct. Less pain and with pain. Yeah. That should be the proper terminology. So that is one. Secondly, at the same time, I do not know in the interest of Maharashtra, but in cities, major metros, you do have fussy parents who do, and not that the common side effects like induration, redness, swelling, erythema, they are not uncommon with wholesale pertussis containing vaccine. Problem occurs especially when you inject and you withdraw the vaccine in this needle in a hurry. Along the track, there is invariably some leak, and this adjuvant containing DTWP, if it enters the subcutaneous tissue, you have exaggerated adverse response in the form of induration, swelling, erythema, and pain. However, there are fussy parents. So my take would be, if parents want to take acellular pertussis, please do not hesitate, because ultimately we should aim at good, coverage. Remember high coverage. Remember all the doses in the schedule should be given. Parents will always ask you.
Pre-primary, toddler dose, school entry dose, and the Tdap. If you give these doses, whether you use wholesale or acellular, it really doesn't make much of a difference. Especially given the fact that we are far away from 85-95% coverage with booster doses in our country. So there is ample natural boosting opportunity also. So while we say that wholesale pertussis is a good vaccine, do not unnecessarily criminalize the acellular pertussis containing DPT vaccine.
So how do you, because the parents will always say, sir, aap batao kaun sa lena hai. So what do you tell them?
So I tell them, I place fact before them that wholesale pertussis vaccine will give rise to some adverse reaction, but by and large, they are not very severe. So your pain, which is very short lasting, fever, maybe a day or two. And there is always paracetamol, which can take care of it. So at the same time, not that, because many parents, because of these guidelines which have come out and the discussion that happens amongst the pediatricians and the company taking their fight into consultant's chamber, there is a lot of confusion amongst parents. Many parents now upfront come and would ask you, sir, painless है तो उसका effectiveness कम है क्या? Is it less efficacious vaccine? So
दर्द नहीं होगा,
दर्द नहीं होगा, but
दर्द नहीं हुआ तो इफेक्ट नहीं है.
scientifically it will be incorrect to say that they are less efficacious.
So I personally agree with Vijay. I think in metro, it's the fussy parents. I think the pediatrician is quite open to use any of the two. But I think it's the parent who actually have had the Google search or they have their own knowledge. And they only, before you can explain to them, they only tell doctor painless wala injection. So I think both vaccines are good.
Basically,
personally-
IAP, ACAP has already said that basically during first year of life, whether you use wholesale pertussis or cellular pertussis, the titers are going to be same. Protection is going to be same.
But I will ask you further questions in subsequent slides where we
is
can
what-
discuss it again.
Secondly, I just
So
wanted
don't
to
think
say
that
about
the discussion has stopped here.
I just wanted to say one contraindication about encephalopathy after DPT
So
vaccination.
that we'll discuss. Sir, Rajendra sir will discuss that issue.
Okay.
So friends, I think the take-home message that both the wholesale pertussis and acellular pertussis vaccines are good, highly effective, and it is helping us in preventing all these three important diseases. So counseling is the most important part where you must talk the correct things and you should never say it is painless and it is painful. Give them the proper information. Let the parents select the vaccine and you continue. But no patient should go without DPT is a rule. I think that should be our take-home message for all the participants. Thank you, sir. Now the question for Rajendra sir. You were discussing about the things. Lot of confusion with the contraindications and precautions for administering DPT. What is the confusion? What is the absolute contraindication and what are the these precautions?
Absolute contraindication till date is basically anaphylaxis, and anaphylaxis.
Correct.
Encephalopathy within 7 days of DPT vaccination has been debated long, mostly probably with this Lalwani sir and other ACAV member probably will remove it and convert it into precaution, because whatever encephalopathy which has gone with DPT has been all Dravet syndrome which has caused encephalopathy. So basically only anaphylaxis is the only DPT contraindication. Precautions, yes. Precautions are inconsolable cry for more than 3 hours. 48 hours, you get a convulsion. Then you have
High-grade fever.
high-grade fever more than 40 degrees, or you have hyporesponsive, hypotonic episodes. All these are precautions, but they are not contraindications today.
And I think contraindications you cannot give the vaccine, whereas in precautions you can give the vaccine, but you have to be more careful and observe the child for a longer duration of period to see any complication has occurred or not. This is the excellent paragraph which I have taken it from WHO position paper, which explains that this is very unfortunate that all the textbooks and all important books are continuing with the encephalopathy within 7 days of getting a DPT and considering this as an absolute contraindication where they have never proved this correlation. Rather, when they have investigated, they have seen these are all cases of Dravet syndrome. So what you have rightly said, in subsequent recommendations by ACVIP, they might remove this indication as a contraindication and might be in the precaution.
Yes.
Now, next question was Sanjay. If a child shows reaction like high fever, convulsion, inconsolable crying, what we have discussed as precautions, can we give DTWP in subsequent doses, or it is preferable to switch to DTA?
See, if the child gets these side effects, I think the child should be given subsequent vaccine which has pertussis component. That's number one. You can't remove the pertussis component.
Correct.
Now,
That
these
is
are
one.
one. That is one. Secondly, you can even give a the wholesale pertussis vaccine, but you need to take slightly more precautions and observe him and sensitize the parents. If you switch to a cellular pertussis, it is not that he's not going to get it, but the incidence is going to certainly come down. So that thing has to be placed in front of the parents, but you can choose any two of the above, the wholesale or the acellular, with a clear that the acellular side effects are going to be slightly less with an acellular pertussis vaccine.
But surprisingly, it also says that the subsequent doses of the DPT containing vaccines, these convulsions and inconsolable crying will go drastically on the lower side.
Yeah, they
So the
say
subsequent doses you may not get the same.
so they say that the local adverse events increases with the subsequent doses, and the systemic adverse events come down with the subsequent doses.
So all these systemic events will come down actually. So you are free to use wholesale or the acellular pertussis. But if, like what you have said, the parents are very fussy and were worried about the first time reaction, then you can give the option of an acellular pertussis to complete the immunization.
Yeah.
Sanjay Marathi, I have a submission here.
Yeah.
See, have you come across a parent whose child has had HHE, Triple H, HHE?
Never, sir.
It is very, I have seen one case in last 36 years. It is a very scary experience that the parents, even hyperpyrexia. So when you have a choice of vaccine where the risk is slightly less, I understand that with subsequent dose of DTWP, the incidence is less. But it has been shown that with DTP, the incidence is definitely lesser than what it comes with DTWP.
Sir, why I'm discussing this? Because the 10% of the population may be affording these vaccines.
Correct.
And 90% will say, sir, aisa ho gaya, hum kya kare? We are left with no medicine, but then they'll insist you take this vaccine.
We made it very clear in the beginning that there is no reason why wholesale pertussis vaccine.
So even in this situation, they can go ahead with the wholesale.
Parent, please do not worry.
I agree.
Hesitate.
You can afford.
Ensure that the child gets full course of DPT, three primary, 2 boosters, and adolescent dose.
Otherwise, you will have lot many dropouts. That is the fear in our. Absolutely, I agree. But then just to give an confidence to those who are using wholesale pertussis vaccine in our periphery and all that, then they should not worry that I will not be able to use this wholesale pertussis in the subsequent doses. But if fussy parents or if you do not want to have the same high-grade fever and all that, you may opt for an acellular in this situation.
Less than 1% of pediatricians must have seen HHE in their lifetime.
It's very, very rare. So I said it is overhyped most probably. I have not seen in 30 years of practice.
It's extremely rare.
Now the question for Yevle sir, what should we do if we do not have which brand of DTAP was used previously? What should be done subsequent?
This principle is applicable to all the vaccines. By choice, please do not interchange the brands. But if you are pushed to the wall and you do not know the previous brand, you can use any brand that is available.
Whatever is. So
Yes.
clear-cut message from Yevle sir. Now question to us, Dr. Lalwani. Baby Rashmi visits your OPD for the second dose of DPT containing vaccine. Mother shows paper with HHE after first dose. What will be your approach for this? I think we have already covered.
Yeah.
I think we'll go ahead. We'll not. Now, is it true that priming with wholesale pertussis is better than priming with acellular pertussis? And what is the difference in immune response if the first dose of wholesale pertussis is given and then subsequent acellular, and the otherwise the first dose of acellular followed by the wholesale pertussis? What is the basic difference in the immune responses?
See, there is very clear this thing that the wholesale pertussis gives you a better immune response, especially the pertussis component of the vaccine. And it is known that the wholesale pertussis vaccine or natural infection or cellular, there's a waning of immunity. But the acellular pertussis, the waning of immunity is slightly more earlier as compared to the wholesale vaccine. That's number one. Number two, immune response. I think if you have a wholesale pertussis vaccine, the immune response is slightly more. There have a lot of school of thoughts. They say that in the primary dose, at least one should be a wholesale vaccine and others should be, especially the first, because the priming is much more. Absolutely. And subsequent antibody response would be better. But I think so, as Vijay told, any of the two is better. We just don't want to draw a conclusion that this is going to be superior over the others. As far as the local reactogenicity of the vaccine is concerned, for the booster dose, the acellular may have a slightly edge because of the less amount of local side effects which we use. But actually, if I have to look at my personal practices and our observations, I think the wholesale still, I think 95% of the population still gets the wholesale pertussis vaccine. It's only 5% of the population which gets a cellular. And following DPT, I think we all have seen fever. We have seen inconsolable cry. I think that's the commonest thing which we have seen. And some of us have also seen convulsion-like state occurring within 3 days and encephalopathy rarely. So I think this event, but as Vijay told, if any parent sees that child has an inconsolable cry for 3 hours and has a convulsion, and you give them a choice that there is an acellular, they will jump to an acellular vaccine over the cellular vaccine. That also is a reality.
Do you think that these are the overhyped severe side effects as they are mentioned every time? Suppose you want to support an acellular pertussis, and if you highlight that you can have HHE, you can have seizures, you can have encephalopathy. Do you think that this is a very common side effect which we have seen? Because I have not seen in 30 years. How many you have seen, Sanjay?
See, I have not seen HHE, but encephalopathy, yes, I have seen. Convulsion, we have seen because in medical school, we do get people referred from here and there much commonly. And of course, inconsolable cry, fever, though I think we have seen, but inconsolable cry, we have seen much more commoner, followed by convulsion, followed by encephalopathy. I have not seen HHE till date on records, but I think that's the severity of frequency. But I think so, it is the way we put to the parents. Now we need to judge the parents also. How much is the literacy? How much fussy they are? I think we need to also counseling depending upon fussiness of the parents also. I think so. We need to make them a clear idea.
Sanjay, let us make it very clear that the severe, serious side effects like HHE, inconsolable cry, and very high fever are extremely rare with DTP vaccine, even with DTWP. However, the common side effects of pain, induration, and erythema redness are less by 2/3 when you use acellular.
Yes, absolutely, I agree. Absolutely.
So I again repeat, there is no reason to change over to DTW, but if somebody asks, don't hesitate in giving acellular protection.
Absolutely. So both the vaccines are equally good. Judge yourself about the patients and offer him appropriate vaccine should be our take-home message. The only difference between, suppose the first dose of WP is given, followed by a cellular, the immune response is good. But if you reverse it, then there is phenomenon called as LES. Actually, it suppresses your immune response. And so if you give subsequently wholesale pertussis, you may not get the same response of wholesale pertussis if you would have given the first dose. So therefore, in case if you want to give one dose, then prefer a wholesale pertussis, followed by you have an option of giving a cellular or an wholesale pertussis.
Sanjay, can I ask a question to Khadke sir and Sanjay? They are there.
Yes.
You had a ACVIP meeting.
Yes, sir.
There are a few papers which talk about most of the skilled vaccine act on prime boost principle, and we have multiple doses in the primary series. And it is said that if you use first dose as WP, the subsequent boosting response that you get to the second primary dose is better. But it has not become a standard of care and recommendations anywhere on this earth. Has ACVIP recommended this in their, is ACVIP planning to recommend this?
No.
But this time we are very clear, sir, Sanjay sir. We are going to tell, write in the recommendation that basically wholesale pertussis vaccine in primary series is definitely going to be better than the cellular pertussis in primary series. That line is going to come probably. I talked with Kasi sir. He is always saying that basically at least one dose of wholesale pertussis followed by acellular pertussis is okay, but at least one dose of wholesale pertussis is necessary.
So we'll wait for the ACVIP recommendation and then we'll have a good discussion again.
I think it will be contrary to the WHO position paper of 2000.
Correct.
For primary series, acellular pertussis vaccine is actually good. Anyway, let's not get into the common.
Now these are the two clear-cut situations, Dr. Rajendra. You can just give and take a message. Rakesh, 3 months old immunocompetent male child, was due for his second dose of DTN. A doctor was not having the dose. He injected Tdap, thinking that this is also a cellular having the same type of component, only that the sequence has changed. Do you think this is a valid dose or invalid?
It is invalid dose, sir.
So what is the principle?
Principle is basically primary dose should be
DTAP. or DTWP.
DTAP, not
So
TDAP.
this is, so never ever used Tdap, which is available as Boostix or Adacel, in primary doses of DPT containing vaccine. That should be
Otherwise also it is licensed above 7 years.
Yeah, but then see, lot of confusion will be there.
Okay.
Now the same type of patient who is 18 months old and he was due for DTAP, but again Tdap was given. So should it be considered as valid or invalid again?
Prior to my knowledge, it was only 5 years dose for Tdap was considered valid. But later on, I searched the literature and 18 months is also valid.
So CDC says if the boosters have been given, unfortunately Tdap was given, still it is considered as valid, but ensure that he has received subsequent doses of DTAP. So 18 months and 5 years is never recommended to use Tdap, but if it is given inadvertently, should be considered as valid. I think this is
Sanjay, let's not draw this conclusion that Tdap can be given at 18 months. The people will take a long.
I said very clearly, it is not recommended at all. And every book says it is never to be given. But if unfortunately it is been given, don't repeat with the DTAP or DTW.
So we should summarize that full dose DPT should be given to children below the age of 7 years.
Absolutely.
However, inadvertently, if either booster is administered as attenuated dose DPT, it may be considered as valid. Not to be done in primary stage.
Never to be used in primary doses. It should be very clear to all of us.
Yeah.
Sure. Now, lot of confusion, Sanjay. Lot of confusion with different components. Now you have an acellular pertussis with 2 components, 3 components, 5 components. Some countries will say we want only 5 components. Somebody will say 3 components. India is the country will accept any component vaccine. Then different studies. One says monovalent component with a higher concentration gives you better protection against the severe disease. Therefore, you can use a single component. Somebody will say, like after the outbreak in America, they say nothing less than 3 components should be used in our vaccine schedule. And some companies will say we will not accept less than 5 components. So why there is a confusion? Is there any difference in the vaccine efficacy? And are they interchangeable? Or all the components, all the vaccines, irrespective of the components, they're equally good? What do you think?
See, there are 5 antigens in a cellular. First is a pertussis toxin. Second one is a filamentous heme agglutinin. Third is a pertactin. And the fourth and the fifth are the fimbrial antigen 1 and 2. Now, I think there are very clear, the acellular pertussis vaccine, which we have in practice in India, the 2 brands which are hexavalent. I think the one from the GSK is it has 3 components, and the one with the Sanofi has the 2 components. I think the literature search says and Cochrane database says that any vaccine which has 1 antigen, the most important is the pertussis toxin. So actually, it doesn't make any difference whether it is 2 components, 3 components, or 5 components. So I think we can use any of the brand. There is enough literature and there are enough studies done across developed countries which shows that. That's number 1. Number 2, I think so that we should not draw any conclusion from the brands part of it. And interchangeability, as Vijay has told, is not permitted ideally. If you use any of the acellular practices, try to keep the same brand. If you are not able to retrieve or know, you can give any other brand. But it doesn't really matter whether it is 2 components, 3 components, or 5 components.
But CDC does not allow. CDC says we want only 5 component DTAP. We will not accept anything less than 5 components.
Yeah, but I think
see the only only country where single component is used is Denmark, and which has shown that basically even a single component is sufficient to control the pertussis epidemics in their listing. Rest of
sir, your final answer, sir.
See, pertussis toxin is the most important component, number 1. Number 2, no 2 acellular pertussis containing DPT are comparable. One should remember. They have been studied in different population at different epidemiological timings. And so it is an unfair comparison to compare 5 with 2 or 3. However, observational studies have shown that there is no difference whether you use 2 component, 3 component, or mono component. Say Sweden has used single component. They have had excellent control of pertussis only because they have excellent coverage.
Yeah.
And that particular vaccine studied in that country has shown excellent efficacy. I would urge each one of our Maharashtra member to read the WHO position paper on pertussis published in 2015.
Yeah, so that
It's a
reference
very
was from
good
that.
read.
Excellent.
Very
excellent.
good read. And please read, all your doubts in mind will be clear. Of wholesale, acellular pertussis, falana, nikna, sagat त्याच्यात एकदम clear दिलंय.
Yes.
And
that-
GSK, which was claiming that their 3-component vaccine is superior to 2-component of Sanofi, they were admonished by the drug control authorities, and they were about to be penalized for, and they were given strict warning not to make such tall claims that 3 is better
Yeah.
than.
So friends, very clear-cut message from all the 3 panelists. All the different components of cellular vaccines are equally good. You can select any one which you like, and do not waste your time in discussing what are these 2 components or 3 components or 5 components. All the 3 vaccines are equally good. Preferably do not interchange, but if subsequently the vaccine is not available, then use whatever vaccines you have and give it. Dr. Rajendra, you will take this. This is a photograph.
Okay.
A child has come to me with this kind of a reaction after, I think it was second dose. And then this is the reaction, what this could be.
Now the vaccine is given on thigh.
Yeah, you can say it was given on the,
Vaccine is given on thigh, and you have a swelling on the arm.
because this is the only, no, I will clear it, because this is the only good photograph I could get it. You can consider this vaccine was given on the thigh, and this is a photograph of that.
So if this is the situation, then probably we are dealing with something what is called as the Arthur's reaction. Because the vaccine is given on thigh and you are getting a swelling on the hand. And
No, don't go by that. Yeah. Then you will say it is serum sickness. No, this has occurred within 3 days of giving the vaccine. Now you tell.
Yes. So it is basically a hypersensitivity reaction which has caused this type of a illness.
This is not very uncommon, and this is seen when you have good antibodies already present in your body. When you give this antigen, there is an antigen-antibody complex, which is basically responsible for the vasculitis. And this local reaction, because of this, is called as Arthur's reaction. When usually it is coming after, say, 8 to 10 days and involving multiple sites, it is again type 3 hypersensitivity, but we call it as serum sickness.
Yes, sir.
So both are same. And how do you manage this Arthur's reaction?
See, if it is a binary reaction, you can give it antihistaminics only. But if it is a severe infection, a severe manifestation like polysinusitis, or you have pleural involvement, you have cardiac involvement, you have gallbladder involvement, then you can use steroids also.
Steroids. Otherwise, local treatment is more than enough in maximum number of cases. Arthur's reaction is not very uncommon. Because of the way we are misusing tetanus toxoid injection, I think we should have more number of Arthur's reaction cases.
Yes.
So this question is for Dr. Yevle. Sir, is it necessary to vaccinate the child with DPT if he had confirmed diphtheria or pertussis infection? Sir, unmute, sir.
You need to vaccinate a child after recovery from diphtheria and pertussis because it does not confer a robust immunity.
I think that is a clear message. So continue vaccinating. Sanjay, a mom comes in with the 19-month-old. She reports that her mother's sibling, Mosi or Mama, for the child, has a history of severe reaction to pertussis vaccine in the mid-1990s. Now, mom is reluctant to give her child pertussis vaccine. Should we be concerned about the mother's family history of a severe reaction to pertussis vaccine, or you can neglect this?
I think you neglect this. There is no genetic basis for it.
Correct. So such things should not be considered. Even there is no question of contraindication, and you should go ahead with this. So family history of pertussis reaction is not an even to be considered in subsequent injections for this child. So this is the question for Yevle sir. Sir, Ramu, 7 months old male child, visits your clinic for vaccination. He has received only BCGA, BOPV and first dose of hepatitis B. What schedule of DPT containing vaccine you will suggest? 6, 7, 8 months or 6, 7, 13 months? And what about the first booster and when?
So I would give him 6, 7, and 13. 016 is the rapid catch-up, which is recommended in a child who has never received any dose of DPT in the past. So 016 is acceptable. And the 13-month dose in this case will be taken as your booster dose. The principle is the minimum interval between the third and fourth dose. Here, of course, the child has not received anything. So you can jolly well give him the first booster dose at when he...
I think we'll have to give him.
Yeah, we'll have to
because
give
then
we'll have to give him.
we'll have to
And
give him a booster also.
And the second booster also.
So friends, take home message is a catch-up vaccination. Anytime the patient has missed at least one dose and now he has come for the vaccination, you should consider the situation as a catch-up vaccination. And catch-up vaccination schedule is 0-1-6 months. And the minimum gap between the second and the third dose in this situation may be 4 months, not 6 months. But when we'll consider that in subsequent days. So 6, 7 and 13 months is the right schedule. We'll go ahead with the first booster after 6 months of the 13 months and the 5 years booster will continue. Thank you. Now let us go to the DPT boosters. Dr. Rajendra, do we need DPT boosters and how many are recommended by ACVIP? But why you do not need DPT? We need DPT boosters, but no boosters for hepatitis B vaccine, which was covered in Sanjay's talk. So you can just give the take-home messages for the audience.
See, basically, why we need a DPT booster is basically weaning of immunity as the age advances. There is a weaning of immunity, and so as to boost this immunity, we require booster doses. And as 5 doses are already recommended by ACVIP, but maximum you can use 6 doses of DPT boosters, a DPT vaccine. Why we need DPT boosters? Because hepatitis B is a long incubation period where basically the anamnestic response and the memory cells are active. So even if you give a primary series of vaccination with hepatitis B, your memory cells are going to work for you.
Whereas in DPT, the short incubation period will not allow you to wait for that short for the secondary immune response. Therefore, you have to maintain the antibody level. So you have to give the boosters for a disease where there is a short incubation period.
Same is about the pneumococcal, Hib, and meningococcal.
Absolutely.
Where you have a short incubation period. So even if you have a good vaccine, you cannot really wait for the gap. So you require a GMT titers to be so high that it will be disease protective.
Correct. So the question of short incubation period and a long incubation period.
Yes, sir.
Now till 7 years, till what age you use DPT and DTAP, and after 7 years, why TDAP? Why
this is
this
already
change?
explained by Arthur's reaction, which we get by repeated TT vaccination.
No. I said up to 7 years, we use DTWP and DTAP. But 7 years and 1 day, we say use TDAP. So what is the basic reason for this? Why you want to use low dose of diphtheria and pertussis and a normal dose of tetanus? After 7 years, it is basically because of the higher reactogenicity.
Yes.
So because of the reactogenicity, so it is very clear, up to 7 years, you can use DTWP or DTAP. After 7 years, you use TDAP to avoid reactogenicity. Dr. Yevle sir, Mahesh, who has received 3 primary doses of DPT before 4 months of age, attends OPD at 11 months of routine checkup as he has to leave the city as family shifting to Dubai. His pediatrician advises TCV, DPT booster and flu vaccine. Is it a valid dose of DPT booster?
Yes, as I said before, the child who has completed his primary series, the minimum, the booster can be given at an interval of 6 months. So he has taken his 3rd dose at 4 months and now he's 11 months. So 7 months have lapsed. So that DPT booster can be taken as a valid dose.
Sir, isn't it that the age should be 12 years, 12 months above?
Because
So you cannot give less than 12 months because this
No.
is what the book says, that the first booster has to be given after the age of 12 months.
No,
And
but-
the second booster should be given after the age of 4 years.
No. In fact, there is a strong recommendation, especially if the child has not taken any IPV and there is an opportunity and standalone IPV is not available. You can use it as early as 9 months also.
No. This situation is that he's just leaving the country and he's going to Dubai. So that does not mean that he will not get DPT vaccine in Dubai. So here,
I'll have to check,
I have
Sanjay.
gone through the CDC recommendation.
As far as I remember, 6 months interval is good enough between the primary series and the
This
booster.
age criteria has been
Age
given in
criteria
CDC.
12 months. I'll have to check.
Yeah, and for second booster it is 4 years.
Yeah,
So you cannot give the second booster with the gap of 6 months if the age is less than 6 months.
present. Okay.
A child did not have the recommended 6 months interval between DTAP dose 3 and 4. Should it be repeated, Dr. Sanjay?
Yeah, again, Vijay, and I think Rajendra has told that the interval between the third and the fourth dose has to be 6 months. Now, this year it is less than 6 months. So should it be repeated? I think ideally, theoretically, yes, it should be repeated because the gap is not 6 months.
Sanjay, if it is between the third and the fourth dose, the minimum gap of even 4 months is acceptable.
Okay.
Whereas for the fourth and the fifth dose, the gap should be 6 months.
6
So
months.
here still it is considered acceptable if the gap is only 4 months. For the third and the fourth.
Okay.
Now this is the question which I was discussing, we have already discussed. So the gap between the fourth and the fifth dose has to be 6 months and age should be above 4 years. That is mandatory.
This we are talking about.
Dr. Rajendra, Rajesh, 3 years and 7 months old, never received any DPT vaccine in the past. Attends your OPD for vaccination. What vaccination schedule you will advise for DPT? What about the boosters?
Here I would give 0, 1 and 6 months. But at the same time, because this child is already 3 years and 7 months old, so after 6 months, probably there will be an 5 years booster dose. So I will skip that 5 years booster dose.
Correct. And very true, because the third dose which was given and at that time the age was more than 4 years. So 5 years booster is not given. But because you have given the 016 schedule, do you prepone giving TDAP instead of giving at 10 to 11 years? Do you give it at 7, 8, 9, 10 years, something like that?
No. It has to be given at 10 years age.
Correct. So very clear cut message, 016 and booster at the right time of 10 years.
10 years.
Sanjay, if a 6-year-old child is due for the 5th dose of DTAP and inadvertently receives TDAP, I know that this dose counts as the 5th dose of DTAP, but should this child receive another dose of TDAP at the age of 11 or 12 years, or now he has already received, so not
Yes.
required?
Yes.
So there is no compromise. You have to give this dose also.
Sure.
TDAP in adolescents.
Hmm.
I think Yevle sir is not there. So, sir has come.
Bola.
I think this we can skip. Sir, we have already discussed because extra doses of PT will lead to Arthur's reaction. So I think too much of Arthur's reaction. Can we use TDAP as a second booster? Should not be recommended, but if it is inadvertently given, should be considered as valid.
Correct.
So now there are so many recommendations for TDAP. And I personally feel this is very, very important vaccine for all of us. So can you tell us what are all the SCVIP recommendations for use of TDAP after 7 years of age? And second question is also for you, because you are the proper person to answer this question.
So-
TDAP every 10 years.
So first of all, as I said, pertussis control requires regular boosting, and hence it is a must to offer that adolescent booster at the age of 10 years. Number one. Number two, the pertussis immunity that one develops after this adolescent booster dose is not very long lasting. It wanes very quickly. So from pertussis outbreak or epidemiological control of the disease, it does not make any sense using pertussis Tdap every 10 years.
Absolutely.
So one dose is enough at the age of 10 years, but you must give it. That's extremely important. As Dr. Ajendra Khadkar sir said, that diphtheria and pertussis, though they are down, they are not out.
Yeah.
In fact, pertussis is on the rise. A lot of pediatricians, fellow colleagues are reporting a lot of pertussis because of inadequate coverage. As far as recommendation of pertussis, as Sanjay took up in the previous case, even if the child has received a Tdap vaccine at say 7-8 years of age, he should still receive the 10th year adolescent booster dose with the Tdap vaccine. In the past, there was a concern about increased reactogenicity to repeated dose of Tdap. But now again, it has been observed that repeated dose of Tdap does not really increase the reactogenicity. So in the same breath, let me tell you that for catch-up vaccination, a child who has not received any dose in the past, the recommendation that is made usually is Tdap as the first dose, second dose as capital T small d, and third dose as capital T and small d, avoiding the pertussis in the second and third dose. However, in year 2019, the ACIP has cleared it, and they now recommend that Tdap is also fine. So that increased reactogenicity is no longer a cause of concern, and one could use either Tdap TD or Tdap.
Just to complete the recommendations of Tdap, a person who has missed his second booster and he has come after the 7 years of age, give Tdap as an additional dose and give one more dose at 10 years of age. If the age of the child is up to 9 years, then still you have to give an adolescent dose at 11 to 12 years. Suppose the patient has come at 10 years of age and above, who has missed his second booster, or he has never received anything, give Tdap at 10 years, but do not give adolescents. So this 10 years criteria is to be followed. Anytime, suppose you have given a dose when the age is less than 10 years, adolescent booster has to be given at 11 or 12 years. If patient's age is 10 years, then adolescent dose is not required. Then if the patient has come with the injury and you have to use that, for the injury you have to give tetanus, and if patient has missed his second dose, use Tdap rather than using TT. So Tdap has multiple uses, and in pregnancy, I think we'll discuss every pregnant mother must receive an Tdap. That we'll discuss in a second. So there are multiple uses of Tdap. This is a wonderful vaccine, and I think we must use it rationally and frequently whenever there is an indication. Now both the brands are available in the country, so you can use whatever is available. Catch-up vaccination we have already discussed. Now, Dr. Rajendra, what is the difference between the two Tdap products, Boostrix and Adacel? Now both are available. Is there any difference, or both can be used whatever is available?
See, there is a difference between the components which are used in Boostrix and Adacel.
Concentration.
Concentration
Components are
is
same.
different. Components are same, but the concentration is different. So at the end, basically, there is nothing to prefer from Boostrix or Adacel. Both can be used.
Because unnecessarily some companies will say our vaccine is also allowed from 10 years or something. CDC has made it very clear. Both the vaccines can be used from 10 years onwards. There is no difference whether you use Boostrix or Adacel. So both are equally good. This Dr. Yevle sir has already discussed, so we can skip. Again, take home message, Sanjay. A child who has received TDP at 8 years, say as a delayed second booster, what about the adolescent booster?
So I think you have made it very clear. Up to 9 years, you can have Tdap, and then you have to give 11 to 12 years of Tdap. So you repeat a booster dose at 11 to 12 years. And 60 years old had taken a Tdap 5 years ago when a daughter was to deliver as a form of cocoon immunization or whatever.
Yeah.
Now our daughter-in-law is due for delivery. Does she need a second dose now? So this is the second dose. First dose she's already taken
5 years back. 5 years.
5 years back. So in fact, there's no harm in taking the second dose.
See what CDC has
At the,
said.
at the same time, basically the cocooning effect, which was really hyped
Yes.
for so many years, is now denied. That
Yeah.
basically there is no point in giving vaccine for cocooning effect. Rather than you immunize the pregnant woman,
Yes. Now
because
there
it
is
gives
change in the
80%.
concept. They say there is no point in giving every time the caretakers with the DTAP. The best thing is to give protection to mother and to the child. So now say don't give repeatedly to the grandmother or the caretakers the DTAP, rather than give it to the mother and get the baby protected. Yevle sir,
Yes.
if a person received a Tdap vaccine and then had a positive pertussis 2 weeks later, could it be a false positive from the vaccine, or should we consider this as a case of pertussis? The patient had cough, nausea, vomiting for 2 to 3 days prior to PCR testing.
First of all, the vaccine will not give rise to PCR positivity.
Absolutely.
Number two, PCR positivity does not necessarily mean active pertussis disease. You have to correlate in the background of clinical presentation.
So, but the vaccine will never interfere with this PCR
No.
testing, and so PCR
Vaccine
will
does-
never be positive because of the vaccine. So if it is positive, maybe infection, may not be infection.
Right.
Suppose the child has come with the inadequate doses at 4 to 6 years, and he has received only 2 doses of DTAP containing vaccine. How many more doses is required for this child?
If the child has received DTAP vaccine below 1 year, he would require 4 doses. If the child has received primary dose after 1 year, then probably he would require only 3 doses.
Up to 7 years, 4 doses of tetanus containing vaccine is a must. After 7 years, 3 is enough. So for this child, you will give 1 dose after 4 weeks minimum gap and a booster after 6 months to complete the 4 dose tetanus vaccine.
Cool.
Sanjay.
Yeah. So
Sashi, I think we have discussed this.
Yeah, we have discussed this.
I think we'll go again. Now this question, a 7-year-old patient had only 1 dose of tetanus toxoid containing vaccine at 11 months of age. The catch-up schedule says he needs 3 additional doses of tetanus toxoid containing vaccine. Why 4? If he were completely unvaccinated on the 7th birthday, he would only need total of 3 doses. I think this also we have discussed. This is just to emphasize that don't misuse tetanus toxoid injection for every wound. Even if patient is fully vaccinated, it has become a habit for all the doctors and also for the patients. They will go to a general practitioner, will take a tetanus toxoid injection, even in a fully vaccinated child. So I think this is a habit which all of us should stop. Take a proper history of what vaccination he has received. And if he has already received the vaccine, do not give TT, because repeated doses of TT will lead to further arthritis reaction and will have problems if you give multiple doses of TT. Sir, I think, sir, Yevle, sir, you can take up this. Sir, what I have done, I have created 5-6 scenarios just for the audience to get the clear idea. If a dose of DTAP or Tdap is inadvertently given to a patient or the product is not indicated, like Tdap was given less than 5 years or DTAP was given after 7 years, something like that, something has happened. The first step is to inform the parents or the patient that administered dose was wrong, but what corrective steps you will take for the following situations. Tdap given to a child younger than 7 years as either dose 1, 2, 3.
This should not be taken as valid dose. We said it before.
So it is
That
invalid.
Primary doses, you should not use attenuated antigen containing DPT.
Then Tdap given to a child younger than 7 years, either dose 4 or 5.
Dose 4 means the booster dose.
Yeah,
It is
booster first
you try and avoid, but if it is given inadvertently, take it as valid.
should be considered as well.
But ensure that he takes the 10th year dose also.
Tdap or DTAP given to a fully vaccinated child at 7 to 9 years. Accidentally, additional dose was given. Should we continue with the adolescent dose?
Yes, give the Tdap dose at his regular timing.
If age is up to 9 years, repeat the dose of adolescent. If the age is 10 years, don't give.
Correct.
The second question was that. DTAP given to an under-vaccinated child aged 7 to 9 years. He has received couple of doses and now he receives DTAP at 8 years.
So if he's received 2 doses prior to taking this should be taken as a valid dose.
And then give additional adolescent dose.
Adolescent dose, yeah.
DTAP given to an under-vaccinated child at the age of 10 years.
This is your valid dose.
Then this is considered as an adolescent dose and no need to give an adolescent.
Absolutely.
These are the 5 different situations where we can decide what is the vaccination to be done to a child.
So just to again re-emphasize
Yeah.
that full dose DPT in primary series, avoid Tdap in the booster series for first and second booster. But if given inadvertently to a child who has taken full primary series, take it as valid. Regardless, between 7 and 10 years, if the child has been given an additional dose of Tdap, don't forget to give the regular Tdap at 10 years of age.
An additional recommendation has come that those who are above 65 should receive one dose of Tdap, because that is another age group where you have high incidence of pertussis and all. So this is a new recommendation by CDC. Now the last leg of this discussion, Tdap in pregnancy. Not because we are interested in giving Tdap to a pregnant because they will never come to us, but we are more concerned about the newborn baby up to 2 months who is never protected and who is at a risk of developing complications and high mortality. So this intervention has, I think, saved so many kids. Now, Sanjay, what is the science behind Tdap during every pregnancy? This is something new. At one time, we were worried about Tdap even twice. And we would say we will not give more than 1 dose. Now the science says you can give Tdap in every pregnancy. When it should be given, just you can summarize.
So I think there is now a recommendation to give a Tdap vaccine in a pregnant mother. It's preferable from 27th week of pregnancy. The science behind that is mothers given the Tdap vaccine, there is an antibody response and there's a transplacental transfer of pertussis antibodies to a neonate which is born, which in turn protects the neonate in the first 6 weeks of life, because pertussis is commoner even in that age group and it has high morbidity and mortality if the pertussis occurs in the first 6 weeks. So that's the passive transfer. It has to be given in every pregnancy, ideally. And if the pregnant mother gets an accident in the first, she can give Tdap. And of course, there's no need to repeat it because that can have transfer of antibodies in the first 6 weeks. There is a science, they say that when the mother is given Tdap and there is a passive transfer of antibodies from the mother to the baby, and that passively transferred antibody will hinder the uptake of the first DPT vaccine at 6 weeks, saying that the antibody response to the pertussis component will be less as compared to one which is not primed with Tdap, but still the amount of antibodies are far more higher, far more than what is required for giving the effect. And vaccine efficacy of Tdap in the mother, I think the vaccine efficacy is primarily given for the prevention of pertussis in the neonate below the age of. So it's a highly recommendation. And I think we are made to understand that a lot of gynecologists in their private practice have started at least replacing 1 dose of TD with Tdap in pregnancy. And I'm sure all of us are seeing pertussis more common in the first 6 weeks of age. So I think it's a highly recommended intervention, which should be, and I'm sure we will have more and more policies, even the government laying it down in subsequent years to come.
Sanjay, suppose the mother had some injury to the lower limbs and she was given DTAP at 4 months of pregnancy. Should we repeat again between 27 to 36?
Actually, the science says that it can be given between 27 weeks
No,
desirable.
but she has
But if-
already received at 4 months of age.
I think that should be sufficient to transfer the antibodies to the baby.
Because there are no studies saying that more than one dose of TDAP can be given during the same pregnancy.
Yeah.
So at present we cannot give, and there is some transfer of the antibodies. So at present recommendation is only one dose of TDAP during pregnancy. Unfortunately, if it is given before 27, whatever the protection the child will receive. See, the interesting fact what they have seen, not only the adequate antibody titers in a newborn baby up to 2 to 3 months of age, the protection, because they have seen many times the mother is the index case of pertussis for the newborn baby. And that is the importance of the vaccine efficacy for first 2 months is almost 93% to the mother, and it comes down to 67% by 6 to 7 months. By that time, the child has already got 3 doses of DTAP or DPT. So he has got the sufficient immunity to protect himself. So there are distinct advantages of giving TDAP in the pregnancy, not only to the newborn baby, also indirectly the mother is protected, hence the newborn baby is also protected. And safety and immunogenicity has already been demonstrated, it's very safe. So I think it is highly recommended that every pregnant mother must receive a dose of TDAP between 27 to 36 weeks. If pregnant lady does not get TDAP during pregnancy, can she be given immediately after delivery, Dr. Rajendra?
Yes.
She can get that TDAP, but the protection of a newborn is questionable.
Might be indirect because she will get some antibodies and then she will not get the pertussis.
Yes.
If a pregnant person got a dose of TD during pregnancy, how soon can the mother be given dose of TDAP?
1 month after that.
4 weeks.
Anytime you can.
Anytime you can.
There is no gap between TD and TDAP. Anytime you can give it. But here you will prefer to give it between 27 to 36 weeks. Dr. Yevle sir, this is a new research which was published in JAMA Pediatrics 2018. The immunogenicity and safety of monocomponent acellular pertussis vaccine at birth. And where at present it is not licensed to be used, but suppose the safety and immunogenicity is proved of a monocomponent acellular pertussis, where do you place this vaccine in our immunization schedule? And can you use it as a first dose at birth in those newborn babies where mother has not received TDAP during pregnancy? Your comments.
It has a potential of preventing pertussis in this newborn baby who are age ineligible to receive a DPT at 6 weeks of, which is given at 6 weeks of age. But if there is such vaccine which is made available monocomponent, especially in our country where the TDAP coverage of pregnancy is very low, it has a very good potential.
So I think we can have this option of giving a monocomponent because our TDAP coverage is very poor. So
But
we can use this.
When we can give 6 weeks of DPT, why can't we give it on the day one?
Because the studies are only up to 6 weeks, we are not very sure what is going to be the immune response. This is an additional which was given of a single component pertussis, not of a combination. So the studies are between 6 weeks. Less than 6 weeks, you are not sure the immune response. But the study with first dose of at birth and 3 more doses, they have seen the immune response is much better as compared to the 3 dose at the end of 3 doses of DPT or 4 doses containing this AP. So they say there is no difference in, rather there is an advantage. But then that does not mean that all the doses of DPT should be preponed at birth. That first. So this is going to be an additional dose, which is going to protect the child up to 2 months.
So in Thailand, I think this monocomponent acellular pertussis vaccine has been studied in Thailand.
Yeah, Thailand. This is a study from the Thailand. I think this cocooning, I think we have already discussed. I think this is all what we can discuss about the DPT. And we continue to learn when we discuss. Thank you all the panelists for your interactive session, and you have really given all very good take-home messages to the audience. And I'm thankful to you all as well as to MahaIP for this platform where we can discuss a single vaccine almost for 2 hours. I think this is all from my side. Now I will stop sharing and over to Ramakant.
Thank you both Sanjay, Rajendra sir and Dr. Vijay Yavle sir. And the patient listening, still the 74 count is seen of participants on Zoom, and must be there some number in YouTube also, those who have continued it. I think now we don't want to test the patience of participants further. There are too many questions are there, but those could be taken some other time, I think. Only one comment I wanted to make is that we have said that neonatal tetanus elimination have been achieved. So we cannot eradicate, but we can achieve elimination. So same thing is what we are doing about NTP. We are not eradicating TB, but we are having an elimination goal of tuberculosis. So tetanus could be eliminated, not eradicated. So 2-3 questions are there. I think we should take it some other time. Amol, please give the vote of thanks.
Yes, sir. Thank you. Thank you, Dr. Vijay Yavle, sir. In spite of your busy schedule, you joined and have explained all your questions thoroughly to all the delegates. Thank you, Dr. Sanjay Marathi, sir, moderating so well. And it was a 2-hour session, and almost 1.5 hour to 1 hour 40 minutes was there for panel. Lot of questions were there, and they were very well answered by Dr. Lalwani sir and Raju Khadke sir. Thank you, Manaklal Chopra sir, senior pediatrician from Nasik, who had joined till this time, and all the delegates. Post-session link will be shared soon tomorrow morning. So those who have missed some questions and lecture also, they will be they can watch afterwards. So thank you all office bearers of Maharashtra IP branches, delegates across India, and pediatricians from Maharashtra also, and pediatric residents also, for your patiently hearing. Thank you, one and all. Good night.
Thank you, and see you all on 7th of May in Mumbai.
Yes, sir. Yes, sir. Yes, sir.
Yes.
To all 7th of Dr. Lalwani, Dr. Khadke sir, Dr. Sanjay.
Madam, meeting
Yes.
end kara.
Please
7 तारखेला भेटूया.